Hey guys, welcome to this pharmacology review on the drug class thyroid hormone replacements. I'm Dr. Busti, your faculty and host on This Is Why, a show that helps healthcare professionals transform their medical knowledge from what to why. In my 30 years of experience as a nurse, physician, and pharmacist, I found that learning to understand enables us to impact patient-oriented outcomes the most. The use of thyroid hormone replacement can do just that, if we use it correctly. Now, some may not consider hormone replacement therapy for the thyroid difficult or something that is that relevant, given how common it is. However, synthetic T4 is known as levothyroxine and is actually considered by most a narrow therapeutic index drug, similar to concepts like we would see with digoxin and lithium. This means that not enough thyroid hormone replacement can lead to problems, but also too much can lead to other problems. And we're going to talk about some of those here, but many of them can be life-threatening or lead to additional chronic medical conditions and exposure to more medications if used wrong. So that leads us to ask the question, why is it relevant to learn about replacement? Well, in part, I gave you some justification in that intro, right? Where we talk about the narrow therapeutic index nature of this drug. What that means is that a very small amount of drug exerts a larger biologic effect. That could be good, can also be bad. Thyroid hormone replacement impacts almost every single organ in your body and its metabolic activities, your brain, your heart, reproductive system, even skin and hair. So using it wrong can lead to scenarios like unexplained weight loss, which if the patient was already thin, that would not be good. Altered mental status, weakness, cardiac dysrhythmias that can put the patient at risk for strokes. In certain special populations, can even cause miscarriages. So now we need to talk about what drugs make up thyroid hormone replacement. So there are a couple. One is the synthetic T4 known as levothyroxine. The second is desiccated thyroid. This comes from a porcine or bovine derived source that includes both T3 and T4, which we'll get to in a minute of what those are. And then lastly, there's liothyronine, which is synthetic T3. So those are the main sources of hormone replacement. The last two that I talked about, desiccated thyroid and the synthetic T3, are rarely used, should not be used. They're not the drugs of choice. The drug of choice in patients needing thyroid hormone replacement is synthetic T4 or levothyroxine. And we're going to talk here in a minute about why that is the case, but when you start forcing the patient to receive T3, and they don't have to have it delivered to them that way, then you can see more side effects without changes in the impact on the thing that you're trying to control at baseline. So what are some of the indications for which we use these drugs? Well, in a chronic setting or ambulatory care outpatient environment, that condition is typically clinical hypothyroidism. Why do I use the word clinical? Because there is subclinical hypothyroidism, but those patients typically don't have symptoms and don't always need treatment. They may eventually need to be put on treatment, but they're not actively needing treatment. In the inpatient or acute care side, typically where altered mental status is a presentation, patients can develop mixed edema coma, which is basically a very severe form of hypothyroidism. Okay, so now we need to move on and look at how the indications and these drugs align with their mechanisms, because that makes sense of why would I pick a formulation that has some T3 in it. So let's jump into that now. Okay, so it's really important to understand where these drugs are working, but there's also the issue of monitoring. Remember, you're giving somebody a hormone. You're impacting organs and tissues. So as it relates to thyroid hormone replacement, the two organ systems that we're most concerned about are the brain, which we'll look at here in a minute, the hypothalamus and the pituitary, which is communicating to the thyroid gland, okay? Now we partner with anatomy.app, highly recommend it. We provide you a referral in the notes associated with this episode. Feel free to click on that and utilize the service if you need it for your own study or personal benefit. Now, what I'm going to try to do is show you some of the 3D anatomy, and we're going to walk through the various components, but I want to explain some of the why it becomes relevant when you're managing these patients. And I realize that sometimes diving into some of the anatomy seems like, why are we talking about this? But if you follow me, I promise you it does make sense. It starts to connect dots, especially in other areas as we manage these patients. So I appreciate Bro, he hangs out with us here in our anatomy area where we do teaching of anatomy, that he donated his thyroid gland and some vessels here. Just, you know, he's one of our old residents, so thanks, Bro. Anyway, just kidding, a little bit of fun here. So Bro's thyroid was placed normal. He doesn't have it anymore. But you see some important things here. One is in the orientation of even when we do exams. So when we're reaching up to the neck and we're palpating, we're asking somebody to swallow, we're seeing that and trying to feel that thyroid gland move up and down across our fingertips to look for thyroid nodules. Thyroid nodules can be relevant for potential cancers, thyroiditis, okay? That may be reasons we had to have it removed, which is why we're giving somebody thyroid hormone replacement, okay? The other thing that you see here that's important to recognize, and I'm going to go ahead and zoom in here, so we're going to go to the board, is you can see the extent of Bro's blood vessel perfusion to this gland, which is true for everybody. There are a lot of blood vessels coming right off of these carotids. Remember, carotid arteries are coming right out of the aorta from the heart, so they're under higher pressure and carry larger volumes of blood. So this tissue, this thyroid gland is being well perfused, very well perfused. And it becomes relevant because if something ever happens where we injure this, then it can bleed. In fact, I remember when as a medical student and resident, when we were in surgery, man, trying to do a thyroidectomy, you had serious blood flow and bleeding problems. So you can see all these blood vessels that are permeating now. You also see that we have nerves coming down, and one of those nerves is the vagus nerve that's coming down through here. And there are branches that go to your area of the trachea and stuff. And so also sometimes when people get thyromegaly or thyroid problems, it can affect their voice a little bit, okay? Now let's take a moment and let's look at the thyroid gland a little bit closer. Okay, so this is a close-up of the thyroid gland, and then there's a couple things that are important. One is just its shape, and you don't see a bunch of nodules here that we would palpate as someone is swallowing. But if you turn the thyroid gland and you look at the back side of it, okay? So remember, this is now hugging the trachea. You see that there's 4 areas here, like little rocks, that are buried in the back of the thyroid gland. Those are important, especially if we remove the thyroid gland. Those are the parathyroid glands. So when we do a thyroidectomy, we actually cut these out and we bury them in the tissue of their neck or their arm because we don't want to lose the function of that. But obviously in dissecting out this, you can keep some of the tissue. So if you have somebody with thyroid cancer, this is where we give higher doses of levothyroxine therapy to suppress the TSH so we don't stimulate tissue that may be attached to it. So this is just a close-up of the thyroid gland itself and what it looks like and what also is attached to it that is very relevant. Now let's go to the brain, which is talking to the thyroid gland. Okay, so all endocrine hormone systems have a feedback mechanism. The organ that makes that hormone releases it. It then goes back to another organ, typically the brain, and says, hey, I'm here. I did what you told me to do. I'm present. So don't, regulate yourself. But the brain, but if it doesn't sense that, and it says, oh, we need more, it will release a communication message from the brain that goes into the blood that eventually perfuses down to that organ and does something, which we're going to see what happens when we do that here in a minute. But there are two spots in the brain that matter. And this cross section, again, I'll just kind of rotate so you can see the three-dimensional. So we're looking at the right cerebral hemisphere of bro's head. Sorry, bro. But you can see where it sits in orientation, especially with the nose and the cavity. The pituitary is not that far away from it. So over here we have our hypothalamus, and then we have our pituitary gland. And here's your sinus cavities here, and your nasooral pharynx is in this area. So it's not very far away. But our hypothalamus and our pituitary talk to each other. The hypothalamus will send a message to the pituitary saying, hey, I'm not sensing any T4 or T3. Let's tell the thyroid to go ahead and make some. And then the pituitary says, okay. And it kicks out TSH, thyroid stimulating hormone. I mean, it's going to do what it says, TSH. It's going to stimulate the thyroid to make a hormone. And now we're going to go back to the thyroid gland, and we're going to zoom in to those cells that make that, and also put it in the context of the circuit, this feedback loop of what's going on so that we make sense. Because when we're administering the thyroid hormone replacement, we are manipulating the organs and their communication with each other, which is why we monitor TSH in 6 to 8 weeks on a steady dose. Okay, so now we're looking at the system, like I mentioned. You see here that this is the hypothalamus on the brain of the cross-section we just saw. It's talking to the anterior pituitary, releasing a thyrotropin releasing hormone. That tells the pituitary to, hey, let's talk to the thyroid gland. It says, okay, release the TSH. The TSH then goes to the thyroid gland, where we're going to zoom here in a minute and see what goes on inside of these cells here. But overall, it secretes or releases T4 and T3. Now, the majority of it is T4, which is why it has a bold, larger arrow. But there's 20% of the thyroid hormone is T3. T4 is less potent metabolically than T3. So T3 is the more potent form of the two, but has the shorter half-life. T4 has a longer half-life, T3 has a shorter half-life. And then T3 will undergo some metabolism, which we'll look at here in a minute. Now, what dictates the amount of T3 at the tissue? Peripheral enzymes. Okay, so let's now look at what T4 and T3 is. So I wanted to show you the structures, not because I would expect that you or anybody else to memorize these things. They just put things into context. So let's look at the structures here and see what makes it T3 versus T4. It's really just about the iodine, okay? So T4 up here is over here, and then you see T3. And then if you were to count the number of iodines on this thyroglobulin, you see here, there's 4. So there's 1, 2, 3, and here's the 4th one. Now this one is circled because over on T3, that's the one that's missing. So it gets deiodinased by an enzyme by deiodinase. The iodine gets removed, and this is the more potent but shorter duration of action form. So how do these molecules get like this? Well, let's zoom in this area so that we see what's happening at this level here. All right, so now we've moved in and we're looking at the thyroid follicle or follicular cell, and there's a follicular lumen, and then over here is a blood vessel, the blood flow coming in. Remember, we saw that, all that blood vessel go into the thyroid gland. And when we eat foods and things that contain iodide, it gets taken up through a transporter. And these transporters can be upregulated in part by some of these effects on TSH and cellular biochemical reactions. But this iodine moves in and it eventually gets placed on thyroglobulin. And TSH is driving that. It is telling it to iodinate these thyroglobulin molecules to make T4 and T3. So when you see it then come over here, right, it's going to secrete a certain amount of T4, the majority of it, 80%. Is T4, 20% is T3. It also, you see that TSH is regulating the production of the thyroglobulin molecules to make more. So when we give replacement, it's like giving somebody this. And that will go back to the brain and tell the brain, hey, I'm here. It will also go to the periphery and needs to get converted. And that's what we need to look at next. So the T4 that gets released or that we administer to the patient can go down one of two metabolic pathways. There's type 1 and type 2 deiodinase, and then there's type 3. Type 3 is going to route it towards the inactive, and type 1 and 2 are predominantly going to push the T4 to a more active and potent. Okay? And so that's just another level of this. But this deiodinase, these are targets of drug therapy. PTU, propylthiouracil, propranolol, steroids can all block this. And why might we want to do that? Well, because if we're making too much and we have a thyrotoxicotic state, hyperthyroid state, then we want to slow this down. So we want to do things that drop this. Well, why would we administer some of those other formulations that have T3 in it? Well, because somebody may not have an enzyme to produce the T3 at high enough quantities for them. So they have a genetic reason to need it. But that's not the norm. Most people don't have that problem. And that is why we give patients T4, because we are trying to allow the patient's body and their metabolism to determine how much T3 they need. But it's under the assumption that they make these enzymes. Okay, so hopefully that made sense and brought some things together, but we still need to take that pharmacodynamic effect and align it with some additional pharmacokinetic considerations, because that impacts the way we use them, the way we do in clinical practice. So I have a table that helps us to kind of wrap our minds around the individual agents, how they're similar, how they're different, okay? Now this goes back and aligns a little bit with the mechanism that we just discussed. So on the top, you can see there's no order here of priority, it's just alphabetical. So we have desiccated, thyroid, we have levothyroxine again, which is our synthetic T4, and then liothyronine, which is our synthetic T3. Desiccated thyroid has both that combination, T4, T3. Because of the way it's sourced, it can vary in the amount. That's part of the problem with that formulation. Okay? Now, when you look at the absorption, you can see that one, food impacts the oral bioavailability, specifically those formulations containing T4. So taking it with food can impair the absorption. That then impacts some of the counseling that we offer to our patient. It also impacts the way the patient is using it. So for example, if the patient is taking all of their medicine with food and you've a dose adjusted for that inhibition of absorption, well then that's the way you should continue taking it, especially if they're at their stabilized concentrations. If they're first starting out, it's ideal to avoid taking it with food because it avoids an interference that causes fluctuations. So you can see that the oral bioavailability is relatively good, but on mostly an empty stomach. Okay. Next is you see that these drugs are all highly protein bound. That means when they're floating around in the body, they're on a carrier. And that is most commonly thyroid binding globulin. Thyroid binding globulin also changes in various states, specifically pregnancy. The high concentrations of estrogen raise the concentrations of thyroid binding globulin. Well, why does that matter? Well, if you have a drug like this that's highly protein bound and you increase the carrier molecules or proteins that it's binding to, then that means that there is less free or unbound. Remember, unbound or free of any drug is the component that exerts the pharmacologic effect. Being bound up to a protein floating around the blood is not interacting with cells or other receptors. The free or unbound is the one that exerts the pharmacologic effect that we care about. So, when proteins change, like in pregnancy, the free concentration or the unbound concentration changes. Well, that can impact outcomes in a pregnancy where the developing baby needs that hormone for growth, development, maturation. And if it fails to receive it, can have poor neurodevelopment, and even there have been cases and increased rates of miscarriage. That can be devastating to a family. Now, the other thing that you see here that's important to recognize is the half-life. Now, I mentioned this in the mechanism section where we're talking about the differences between T3, T4. T3 is the more potent form of the thyroid hormone, but it doesn't stick around as long. T4 is far more potent, but lasts a lot longer. So when you give somebody synthetic T4 as levothyroxine, that can stick around for many days, up to a week. Well, that's relevant because it will now take 6 to 8 weeks for that dose, assuming 100% compliance, to reach steady state. So if you check the TSH too early, you may not see the patient at their steady state and make a dose adjustment inappropriately. So it takes 6 to 8 weeks for this steady state to occur on that dose, using that dosage formulation and manufacturer. So if you even switch manufacturers of some of these drugs, that can impact the overall absorption, that impacts the overall effect. Remember, it's a narrow therapeutic index drug. Very small amounts exert a large biologic effect, and it's impacting a lot of organs. Now, what other thing does this apply to? Well, this applies to the frequency of administration. We can give it once a day. That's easy. That's nice. That's good for patients. It's good for providers. But remember, ideally, if they can take it on an empty stomach, assuming that's new start, but if they've been on it with taking their medicine with food and they're at their steady state, their TSH are normalized, then you want to just keep going it that way and not have them stop taking it that way and go taking it on a fasting situation or on an empty stomach. Why would that? Because now you're going to increase the absorption, and that difference of an increase in absorption can be too much for the patient and lead to side effects. So you can see that half-lives influence our frequency of administration. It also influences the steady state when we check TSH to reflect that dose and what we've been doing. Now, you certainly can make a dose adjustments on the symptoms, but man, you want to be real careful with rapidly dose adjusting somebody too quickly, too much. We'll see here in a minute that can lead to significant changes in the TSH. So we have all these dosage formulations that are reflective of the fact that it's a narrow therapeutic index drug. Now, when we first consider the standard doses for most adults, that dose range is 25 to 50 micrograms. And that's the first thing that I want to say. Do not make the mistake of micrograms and milligrams. these doses, when we talk about 75, 125, we're talking about micrograms. So 125 micrograms is 0.125 milligrams. So you got to really keep that straight so that you don't overdose the patient. But early on, the earliest doses are where you see the biggest dose increase. For example, going from 25 to 50 is a 100% increase. But going from 50 to 75 is 50%. And then as you go, you see it starts to go down and stabilizes eventually at 10% changes. So as the dose gets bigger, it's tight. Okay, it gets real tight, small amounts. But everybody needs a certain amount up front. So who do we start with 25 versus 50? Typically patients who are older, patients with cardiovascular disease. We want to err on the side of safety and precaution. So you also see the percent reduction is small as you go down. So this points to having this many dosage formulations in these small units points to the narrow therapeutic range of how these drugs work. Now, I wanted to use this to represent, this is some data from a study including 21 patients who were stabilized on their thyroid replacement. So they were on levothyroxine and had normal TSHs. So this group. The yellow dots here reflect normal, healthy. So if you look at their TSH, they're in the normal range. Okay, and you see that patients kind of sit towards the bottom or lower end. That's usually where they feel the best. But this area in here is all normal. Okay, it's all normal. So what happens if we make a 25 microgram change? Okay, so if you add 25 micrograms, you see that many of those patients, not 100%, many of those patients now drop to low TSH levels. That means the feedback on the brain is higher and is shutting the communication down. So the TSH is getting lower and lower and lower. This is a hyperthyroid state. If you go up by 50 micrograms, all these patients now have low or almost undetectable TSHs. You're giving them way too much. So even a 25 microgram shift, with the exception of the very earliest stages of the dose, cause profound biologic impacts on the patient. Well, the same thing happens if you remove or take away some of that. So if you remove 25 micrograms, you see that they lose control very quickly. The majority of them lose it, especially over 50. So again, small changes exert a huge pharmacologic effect, and that matters. The other thing that matters is that these patients also, if they switch manufacturers. Now, why would that happen? Well, because they're at one pharmacy and they decide to go somewhere else and get their prescription filled somewhere else. And in doing that, that switch from one manufacturer to another at the same microgram can lead to changes in the overall absorption, more or sometimes less. And so that can cause some of their symptoms to be lost or their level of control to be impacted. Whew, that's a lot. You heard me talk about a special patient population and scenario like in pregnancy. Remember that thyroid binding globulin level goes way up. And we talked about the high protein binding of these drugs. Well, that impacts the dosing strategy in that situation. That's different than non-pregnant patients. So you saw that we made fairly small adjustments once we exceeded that 50 micrograms. The adjustments were small because we don't need that much more to exert the effect. However, if we increase the protein binding, we reduce the free fraction. That means we're also going to reduce what's available to others. So when someone gets pregnant and that thyroid binding globulin level goes up, the free fraction goes down. We have to give that patient, the day they find out they're pregnant, at least a 30% increase. And in most cases, patients are going to need, on average, a 45% increase from wherever their baseline was before pregnancy. So you just need to know that. They need to be counseled on that. That is huge. It does impact outcomes. All right, so what are some of the common side effects or adverse drug events that can happen with these agents? Well, you basically are going to mimic the symptoms of someone with hyperthyroid. Weight loss, changes in hair and skin, tachycardia, tremors. Sometimes that tachycardia can lead to AFib. That's why it matters giving a patient, especially with an underlying patient with known vascular disease, is at higher risk of flipping into an atrial cardiac dysrhythmia. And one of them that you would be worried about is atrial fibrillation. Why? Because it increases their risk for cardioembolic strokes, which means if they stay in AFib, which would be unfortunate from the drug being inducing it, now the patient needs to be on another drug, an anticoagulant, right? One of our DOACs or warfarin or something, that are going to have to protect that patient from a cardioembolic stroke. That would be unnecessary, especially if we could have dose adjusted around that. Tremors, these can even lead to panic attacks, anxiety, unexplained weight loss or too much weight loss. I know some people want that, but we don't use levothyroxine or thyroid replacement for weight loss management unless that's the underlying problem. Always treat the underlying problem first, but we don't add on or we don't push the dose to higher levels to create weight loss because it comes with too much other problems. Right? Worsening risk of osteoporosis, especially in our postmenopausal women. Diarrhea, sweating would be, again, more severe. So hyperthyroid states in various extremes, depending on how much they are taking. So you can overdose on this and have some problems. Also, simply changing the way you administer the medicine on an empty stomach or with food can. So we want the patient to stay consistent so that we dose adjust their meds around their lifestyle. Okay, so we know that we have some side effects. Is there another situation where we need to treat something first? Well, that condition is adrenal insufficiency. If you remember back in the mechanism, I talked about the need for steroids to facilitate the peripheral conversion of T4 to T3. We actually use steroids to impact or block that. And so if patients do have a certain degree of insufficiency, they need to be treated first. And many times those patients need corticosteroids. So that would be relevant. Who else do we need to be warned about or maybe cautious? Well, again, we're not using it for weight loss. Those patients with cardiovascular disease or high risk for cardiovascular disease need lower doses, and we need to titrate a little bit slower. Lastly, those patients with diabetes, they could experience some improvement in their weight, and they might see changes in their insulin requirements or dependency. And so just be cognizant as you treat one condition, it can impact another condition. Okay, what about drug interactions? Well, I want to point you to a table, again, that we have available at thisiswhy.health to help us wrap our minds around some of those things. Okay, so on this table, again, that is available for download for members at thisiswhy.health, we offer free accounts for you to be able to access collection lists, playlists, tools like this for studying or for your use in teaching, again, studying, or for your students and residents and those kind of things. So use it as you feel free. Now, you see that there's three columns. The column on the left is impaired absorption. The column in the middle is increased clearance. And then the last column on the right is impairing the ability of the T4 to get converted to T3. Now, absorption can be impacted by a number of things. One of the problems with levothyroxine in particular is its charge. It has partial charges on it that then can bind to other or opposite charges, and the opposite charge happens to be cations in this case. So co-administering your levothyroxine with calcium, aluminum, magnesium, iron, any divalent, trivalent cation can bind to and chelate and prevent the absorption. So simply taking a multivitamin at the same time as your levothyroxine could impair the absorption. Fortified orange juice with calcium can impair your absorption. Any supplement with those cations can bind to and decrease the absorption. So that's why we separate it by 2 hours at minimum. Now, there are other drugs in that list that combine, so phosphate binders, right? That's a classic one. Many of the calcium salts, not just calcium for bones, but even phosphate binders, calcium citrate, aluminum salts that are also used for phosphate binding, magnesium salts that you see in over-the-counter antacids, some bowel regimens. So all of these things are important. What about increased clearance? So maybe that half-life gets shortened. Anticonvulsants are probably the biggest culprit. Carbamazepine in particular, phenobarb, phenytoin, rifampin is not anticonvulsant, but is known to be a pretty strong inducer of the cyclone P450. These drugs are known to do that. Nevirapine, which is an NNRTI for the treatment of HIV, is known to be an enzyme inducer. All of those can have increased effects on the clearance of thyroid hormone replacement. Now, lastly, we talked about that T4 to converting to T3, the more potent form. So you see steroids are there. Again, that's why we might use them in the acute. Beta blockers, and specifically propranolol, has been known to inhibit the peripheral conversion. Propylthiouracil, which is one of ithonamides that are used to treat hyperthyroid conditions, but we use PTU in the acute hyperthyrotoxic state because it can block that. So all of these drugs can do that and negatively overall impact. Now, amiodarone does a couple things. It does contain iodine, so that can affect the blood flow to the gland, but also a small degree impact the peripheral use of the hormone. Woo, that's a lot, guys. I know it's hard to keep up with sometimes, but don't be afraid to, just let it soak in. Don't try to memorize everything. Remember, we're trying to learn to understand. When you understand the why, you're more likely to retain it and apply it. So you may have to come back and listen to some of this stuff again. That's normal, that's expected. Listen to it as much as you want and need. But, and then once you apply it in clinical practice, it starts to really, really make sense. So what about monitoring parameters? Well, things should make sense. We're affecting the cardiovascular system, we're affecting organs. So blood pressure, pulse. Too much of that can raise them, increase your pulse, cause tachydysrhythmias. So on your physical exam, do you hear, when you're listening to the heart, an irregular beat? Or do you palpate the radial pulse and feel an irregular beat? Has their weight changed? Is their skin or their hair changing? Right? All of those point to, hopefully, improvements in their symptoms. Now remember, from a lab standpoint, in all patients, you need to monitor the TSH. Remember, that's the communication piece between the brain and the thyroid gland. It gets the feedback from either the thyroid gland that's making it or you taking it. The brain doesn't know where it's coming from. It's just like, oh, there's some T4. But remember, it takes 6 to 8 weeks for that dose, taking it every day the same way, for it to fully reach steady state. So if you adjust too early at the 2nd or 3rd week, you could put the patient in a hyperthyroid state because you're not seeing them on the trajectory of being in steady state, you're seeing them on the rise. So interpretation of labs becomes really important to the manipulation and the dosing of this drug. Now, if the patient is a female of childbearing age, then a pregnancy test is relevant, especially if they have baseline hypothyroid state. They need to be counseled, but they also need to be tested, because remember, we're going to start with a big dose increase the very day they find out they're pregnant. Okay, so are there some other things to counsel the patient on? We talked about compliance, adherence. We talked a little bit about the impact of food. We talked about the impact of cations like magnesium and aluminum and iron. We talked about pregnancy and the need to find out when you're pregnant as soon as possible if you are trying to get pregnant and you know you have hypothyroid. But there's a couple other things. One is smoking. If you stop smoking, you may need a higher dosage. Smoking is also one of the things that increases the clearance. So around that, you can just dose adjust it, but it may take 2 to 3 months to get them back to a dose. Again, probably a little bit higher. Avoid biotin. Okay, that's one of our vitamins. 3 to 5 days before doing thyroid testing. Why? Well, because too much of it, especially in higher doses, can lead to falsely low TSHs, and as it relates to the T4, T3, it can lead to falsely high. Okay, so we recommend patients avoid for at least 3 to 5 days before testing or coming in for their labs. All right, so there's a lot of good stuff there. But elevating our medical knowledge into the level of understanding is the goal. Why? Because we want to improve outcomes. And pregnancy is one of those. Another example of another special case is cancer. So let's say you have thyroid cancer and the thyroid gland is removed. So you have a thyroidectomy. Well, you may not be able to get 100% of the tissue. And so in those cases, those patients are having their thyroid gland removed, we got to replace them with thyroid hormones because we pulled it out, the gland that makes it. But you're actually going to dose this thyroid replacement at a much higher dose than normal non-cancer patients, because we don't want to do anything to stimulate the thyroid tissue that could be left behind or is cancerous. So that means in those cases, we want the TSH to be really, really, really low. Okay. Now, we'll cover that in another episode in the medical rounds, and so you can find that at thisiswhy.health, but wanted to make sure that you see that when we understand why and how to apply this, it can impact outcomes. Now, we have this topic along with other ones for various endocrine disorders and collections and playlists available at thisiswhy.health. And again, some of the tools that we used here today, you could download for your own study, use, share them. If you got students, residents, and you teach, feel free to use them. The goal is to help each other out. All right, so synthetic T4 is the drug of choice. If you're running to T3, you have some peripheral problem, okay? Remember, there's no benefit from an evidence standpoint for using T3-based regimens unless you have these enzyme deficiencies. You also want to requires us to be careful in the titration. Remember, it takes 6 to 8 weeks for that TSH to stabilize. Too much can lead to side effects. Not enough, especially during special situations, can be detrimental, like in pregnancy where we see increased rates of miscarriage. All right, if you're watching this on YouTube, please like us, subscribe, and then go over to thisiswhy.health and join or sign up. We'd love to stay in touch with you. And I hope that you found this pharmacology topic review helpful, and we'll see you next time.